Welcome, everyone. We are very, very pleased to have with us today Anup Chauhan. Anup is a physician. He is a clinical physician of respiratory medicine. He is also professor of respiratory medicine, the executive director of research for Portsmouth Trust Hospitals. He practices in Portsmouth, teaches also in Southampton. He is one of the UK's foremost experts in respiratory disease and a key researcher. And likewise, not only on the clinical side, but also on the behavioral side. And we're very, very happy to have him with you. So have him with us. Thank you very much. And welcome, Anup.
Thank you. Thank you for the invitation, Kevin. It's good to be here. And hello to everyone.
Great. So I'm going to dive right into it. Anup, as you know, we like to ask 3 questions of our guests. And then we actually cheat and ask them a 4th question. But let's get to the 3 questions first. So first question, you might be the first practicing physician that we've had on the series. And I know that you are very sensitive to the importance of addressing patient behavior. So my question to you is, what do you think is the best way to inform physicians about the problems surrounding adherence?
It's a really good question, Kevin. And my experience as a clinician has taught me several things, is that, especially in my area of expertise, which is asthma, where we're unpicking somebody's asthma or ascertaining the reasons why it might be bad, there are usually multiple things that are often provoking it, such as comorbidities, obesity, gastroesophageal reflux, sinus disease, and all of those. And as a clinician, we often try and pick them out and then give them the appropriate treatment. But I realized that adherence is a comorbidity, but most clinicians actually don't recognize it as such. They can tell you about all the other comorbidities in asthma, but when you asked about adherence, whether it's an asthma or any other condition, we don't really know about it. And so therefore, by recognizing that adherence is a really poorly taught phenomenon, certainly in medical and healthcare professional education, it makes you think, well, the way to address it is largely through education. So I believe that we need to change the way we approach adherence throughout our whole educational system. So I think, it should be a core curriculum in our undergraduate education, all healthcare professionals who are going to be dealing with patients and medicines. So whatever walk of life, whether you're a pharmacist or a physiotherapist or anybody who's going to be prescribing medication, is really important to understand that making sure that medicines work is not writing the prescription. That's the easy bit. The hard bit is recognizing what drugs to give our patients, but ensure that they're given the right support to be able to take the inhalers properly. So I think education is key, but also education that then needs to be physically available commonly. So I think digital as a means of adopting and transfusing that sort of knowledge around adherence is important. And part of that process is understanding how can digital help adherence. And the key is recognizing the problem, quantifying the problem, understanding what components of the problems are by using interrogative digital questions and techniques, and then being able to use that sort of digital means to try and change people's often perceptions that belie non-adherence as well. So I think digital and education are key things to inform physicians and healthcare professionals about adherence.
That's a really interesting take, that adherence as a comorbidity. And your remark about education for physicians, as a professor of medicine, in the UK, for instance, is that topic approached? And if so, could it be approached better in medical studies?
I think a lot of pharma studies, you find a huge placebo response, and especially in asthma in particular, we often get a huge placebo response. And we see that across various disease, but asthma seems to be particularly prone to it. You see many patients who are on biologic treatments who have seemingly very poor control of their asthma. They're put onto a clinical trial where they get their support. So in the research support, you see your healthcare professional regularly. You have better means of communication. If you suffer an adverse event or any other outcome, you report it immediately. So it tells us that level of communication between patient and healthcare professional needs to be swift and it needs to be directed. Patients need to feel supported, really, really important. And then at the same time, we often find in asthma trials that the patient gets better, and simply because they're under observation, the observation or support. So we need to mimic what we see in research trials in asthma, where patients are supported. They're often given digital diaries where they are better supported with their self-management, so they can recognize triggers, take their extra medicines when required, how to prevent exacerbations, how to measure their lung function, and all of that you get in a research trial, but it's done really well in a controlled situation. So mimicking some of the key elements that we often see in research in asthma and COPD is key in terms of learning how do we then take the elements of that, strip it down, see what works, and then digitize it in a sense that we can make this sort of technology available to so many more patients as well. So something about asthma that tells us that adherence is a huge problem. And what is peculiar to asthma actually is adherence is quite a heterogeneous term, especially in asthma, because adherence will be due to lots of reasons, patients having their own ideas about their disease, or whether they've got the disease or whether they're going to get side effects from it. But also, more importantly, whatever you prescribe, whether you can use the inhaler. We are guilty as a healthcare industry, including pharma. One patient could have 3 or 4 different inhalers, different manufacturers, and they all require a different technique. And it's not easy, especially for older patients with cognitive challenges, to be able to use different kinds of inhalers. So we need to ensure that we can streamline the method and delivery of medicines as well, especially in asthma. If it's a pill, usually straightforward about swallowing it, but when it's an inhaler, adherence is just one thing, but actually you can have good adherence, but if you adhering and your technique is awful, you're not going to get the desired effect. So there is something around asthma where we correct all of that: adherence, technique, education, self-support, management. So we need to encompass that, package it, and then deliver it in the real world for what I believe would be, transformative.
Do you think, when you describe it that way, and the difficulty of the patient to adhere, even if they're willing to do so, do you think that that it should be an obligation, or that physicians should feel an obligation to go farther than simply determining the right treatment and prescribing it, but also in doing what they can to ensure that it's being adhered to?
I believe so. It's really strong, because I think physicians will generally, part of treating a patient in the disease is taking a careful history and getting a level of communication that helps you understand the person. And there's always a person and a story behind each patient, and we're not very good at that. And part of the communication is actually unpicking it, and that's what constitutes a really good doctor-patient relationship. So part of that communication is understanding the reasons as to whether the patient has a disease, whether they're going to benefit from it, understanding their concerns, but at the same time, then using that information to be able to prescribe it. Our problem is that because adherence is so poorly recognized across the healthcare industry, we're only kind of learning more about it now, is that we just don't have the tools to be able to stratify which patients are likely to be at risk of poor adherence. What are the other things that are determining adherence? And also, how can we improve our communication? Because many clinicians are taught information extracting communication techniques. What's really important is that you have that feedback. So that's the information my patient has given me that tells me that this is the next type of question I should ask. Mm-hmm. So we are not trained in the art of communication around adherence itself. Mm. So I think that's quite an important thing. So if you're a surgeon, you will talk about hernias and operations and risks and complications. But if you are a physician where your armamentarium includes drugs and medicines, you should be far more careful about evaluating stratifying your patients for adherence and actually using the information that they give you to serve up a self-management plan. So part of self-management plan is taking the medicines, but part of self-management is actually how can we modify your stories and behavior that will lead you to form good habits and bad habits. So what can we do practically based on where you are as a person, your beliefs, your experiences? You're giving that to me as a clinician. I don't want to be inundated by this experience. I want to make sense of it. And I then want a series of tools. So the things that we're missing is the ability to stratify, the ability to amalgamate, assimilate a plan. And then the third bit is deliver it. How do I deliver it? Because we do know that patients, they'll nod their head and they'll say, yes, doctor, you're really right. I must do better. Must stop smoking, take exercise, take my inhaler. As soon as they walk out of that door, it's a different story. You see them again. And unless you get into a habit forming issue, which we find it really difficult as clinicians, because you only see these patients once in a while, every few months, certainly in my business. So you need to be able to communicate with your patient with that same message recurrently or a longer period of time to be able to form the habits that modify behavior. So the bit that's missing is that constant messaging and ability to, or the opportunity to change behavior. And that's where digital comes in. So it's quite complex.
It's interesting because we like to talk about the idea of, there's a parallel. There's the clinical process, which is you make a clinical diagnosis, you make a treatment decision, and then you administer it. And that likewise, as a parallel with behavior, you should be making a behavioral diagnosis, determining a behavioral intervention, then helping to administer. And what you're describing, I think when you put them together, then we get into this idea of person-centered healthcare. Right. I have one last question for you, Anup, before I lie and ask you a fourth question. So we've talked about physicians, but what about an organization? What about a hospital? You work in a very large hospital. From an organizational perspective, do you think that healthcare institutions can put together structures that can facilitate that behavioral modification for patients?
It's a really good concept, and I believe that's going to be the core of delivering future medicine. So we often use the term personalized medicine to personalize based on biomarkers. So if I know if I can measure serum rhubarb or measure something in somebody's breath, I kind of know what drug to give them. But making them take the drug, or also to making sure that I prescribe the right drug, because that's the other issue. There's no point being indifferent when the doctor's prescribed the medicines or over-prescribed it so the patient gets the side effects. So it's a real art in making sure that your desired outcomes are suited, so your dosage and your drug is tailored to the desired outcome. So that's really, really important in terms of delivering that in the same way. But we recognize, certainly in the COVID pandemic, has really pushed us into understanding patients, but also how do you use digital in every way. And we know this from every healthcare organization who's adopted different innovations and techniques post-COVID, because they've been forced to do that. One of the things we now are doing is virtual consultations. So it's very rare for us now to see patients face-to-face at the moment. So how do we use remote digital communication forms to try and get the same message across as well? Patients prefer it, but part of this is that whenever a patient has a journey or an interaction with a healthcare professional, we mustn't use digital to replace that conversation. I think it's important that we use digital to enhance the quality of that conversation. How do we do that, you may ask? Well, there's loads of ways. So one of the things I would love to know in my patient is that maybe I don't want to spend 30 minutes trying to extract this information when actually the patient is much more willing to give it to some chatbot, and that information is uploaded and that information is then available to the clinicians so they can get off to the right degree of quality consultation. But also, can we then use information that will allow us to get the maximum benefit from the inhaled treatment? So using asthma as an example, if I was to be able to screen a patient digitally about where they are with their adherence phenotype, so I would call it a phenotype, whereas you get the biological phenotypes, my adherence phenotype might be quite different. And how you phenotype these patients, well, there's a real science behind that. But one of the ways I'd love to do is patients to be able to declare their stories. What are their stories that driving most of their concordant, or in most cases, a lot of cases, discordant behaviors. So we know it'll be around beliefs, concerns, and other issues, but how do we extract the belief forming issues, but also how do we then get into the habit that then attaches itself? So if I knew that my patient was, looking at the weather on their app every morning, if their internet tells me that the first thing they do every morning is look at their app or something, or Google search or whatever, or find out what the previous night's baseball or football scores were, great. Can we use something like that in order to attach a habit forming behavior in that same way? So using information that is part of a patient's lifestyle is critical for us to then do the right thing for them. So I think understanding adherence phenotypes, attaching it to behaviors, and then allows the clinician that information to give the right supporting package, because the same support package will be different from one patient to another. So going back to the earlier point, heterogeneity and adherence, we need to have different interventions for different types of adherent behaviors. And it's complex, certainly in my area as well. So going back to that future of medicine, if a patient was to walk into a hospital, I want to know, for example, the demographics, great, got that. I want to know what comorbidities, what medicines have been prescribed. I want to know what the BMI is. I want to know what their adherent behaviors are like. I want to know what their adherence is like. At the moment, we don't do that. Patient comes in with an asthma, you treat them, and off they go. But if I had intelligent systems that tells me, as part of their lung function and their X-ray and all the other information, their adherence risk, or maybe their SPUR profile, Kevin, something that tells me where the person is in base of risk. So use that opportunity to try and modify the behavior rather than just prescribe the drugs and get them out the door like a Formula One car. Spend a bit of time, try and understand them, and then move them on that way. So everything around social interaction, comorbidities, physiology, biology, if we can stratify that together, and then here's a crux of it, if you can build an artificial intelligence system that will allow that amalgam of that information to then prod and nudge the clinician, say in this situation, these are the things you might need to address. It'll allow us a better opportunity. So I think that's where the future chronic care disease model is going to go, information used intelligently.
Well, first of all, that I agree with you 100%, but furthermore, honestly, Anoop, just listening to you, I have like 6 other ideas for further research that we can do. So I'll be getting in touch with you about other studies we can put together to help move from that identification of phenotype directly into intervention. Fantastic stuff. I'm just going to ask you one last. Yes. I'm just going to ask you one last question. You talked about the patient story. So my last cheating question is about your story. I know that you've been practicing in respiratory medicine for quite some time. Was there an event or a person or something that you saw or heard or experienced that really opened your eyes to the idea that more attention should be paid to behavioral issues?
Yeah, I remember a patient probably over 10 years ago where she was a typical severe asthmatic. And this was in the pre-biologic era, so I didn't have an injection to treat her phenotypes. Inevitably, in those days, you ended up treating the comorbidities in the hope that if you treat the comorbidities through the law of marginal gains, you treat every little bit, your combined outcome will be greater. Unfortunately, this patient ended up on oral corticosteroids. It's a no-go area. It's the last thing we want to do is commit somebody to oral steroids, but it's the only way we can control her disease. So I thought. Then over a period of a couple of years, she was meant to be taking these oral corticosteroids, but I couldn't make sense of a blood test at all. There were still surrogates of inflammation being there, and I ended up doing a load of physiological tests and doing scans and imaging, and I couldn't understand why, despite steroids, it was just not working. Then obviously the most important thing was, look, you've got severe asthma, you're supposed to be on steroids, are you really taking your medicines or not? And she denied. She says, no, I'm absolutely taking my medicines as well, which then spurred me on. I cracked on, did some more investigations, couldn't understand why it was. Then I said, look, I've tried everything. I haven't got anything else to do. What's going on? She said, are you really, really taking a medicine? Previously, it had been almost like a bad news session, telling a patient that they've got cancer when you're actually saying, yeah, I don't think you're taking your medicine. You get tears and you get a lot of rejection. And then as a clinician, if you haven't got the skills, you back off and you don't stray down that area. But this time around, I had nowhere else to go. To this lady, I said, look, I've done all these tests. They're telling me that you ain't taking your medicine. And I was quite firm and strong with her. And then we had a cathartic moment. She broke down and said that, yeah, you're right. You know, I'm really appreciative of everything you tried for me. And I thought, everything I've tried, I've been working at you for 3-5 years. I've tried every drug, every scan, everything that I could possibly try, and you just not been taking your medicine. As a clinician, I obviously controlled my temperament, but timing the opportunity around non-adherence is really important, because even if you met with resistance at the first step, don't give up if that is still there, because many patients will resist. And then as soon as we addressed that, I was able to get into her stories. So the mistake I made is I thought I understood the patient, but I actually didn't. Once she opened up, you ain't taking my medicine, then I thought, yeah, why? Tell me about yourself. And then he went into sort of body image issues. They gave her bruising. They gave her a bit of side effects. None of this she kind of told me beforehand. And it made her put weight on. And she wasn't changing the dress size, but she just felt unwell. So as a result of that, she avoided taking the medicine. So I think once I got to that stage where I had a real conversation with her, her asthma improved phenomenally. And I wish I'd just done that earlier. So, you know, every time now, every patient I see, Kevin, first thing I ask, you taking your medicines? Yes, no. And most of the time they do, but actually I don't know whether they are or not. So I took it upon myself that I need to understand adherence better, because I will be doing my patients a disservice if I don't. And I need to understand adherence, and I need to arm myself with the right tools to do the best I can with that adherence. I'm still working on it, but I think I'm probably slightly better than I was 10 years ago.
That's a really, really powerful story. I know, because the thing is too, I mean, how many patients who all the same were doing well still aren't, you know, how many physicians are titrating patients, switching therapies, you know, and just doing their very best simply because they haven't been able to have that conversation, or when they did, the patients, you know, didn't really fully express themselves.
Oh, Kevin, absolutely. We now have even more expensive biologic therapies that patients are escalated onto because of their poor behavior. And unless you address that adherence, not just once, but recurrently, and you really got into that sort of belief around adherence, you carry that non-adherence through the biologic. And, you know, it's taxpayers' money. It's an absolute waste if that non-adherent behavior continues and escalates to even higher cost drugs, because we all pay for it.
Absolutely. Well, Anup, thank you very much. As I well expected, this was a fascinating conversation. As I mentioned before, you've given me a whole bunch of ideas for new research, so we have a lot of things to do together, hopefully.
I look forward to
very
it.
much thank you for your time.
Great. Thank you for having me.